Hello and welcome guys to another power pack session on this subject of anesthesia on this wonderful platform of Unacademy. So I am audible and visible. A quick nod guys. Yeah, so that is wonderful. So let us begin our today's session on anesthesia simplified, where we will be discussing a lot of topics which are high yield when it comes to anesthesia subject, and also I'll be telling you a little tips and tricks how do you remember those tricky topics as well. Yes, these are some of the most high yield topics which have been asked in the examinations time and again. So let us begin with our first topic. Before we begin that, let me tell you where can you find me on the Unacademy platform. Yes, this is the plus batch course that I have recently taken, and you can find me taking all the basics of anesthesia as well as the most important concepts when it comes to anesthesia for cracking your entrance examination. Yes, without this you will not be able to score and get a higher rank. Yes, anesthesia forms one of the very most important basic subjects when it comes to scoring in NEET PG. Yes, as well as this is the batch course link where we have taken integrated sessions, and yes, where you can find me on the Telegram group. This is the link for my Telegram group where we interact daily, where I put the polls, where you ask me the questions directly, and I am more than happy and obliged to answer them. And this is like a personal connection where you can connect with me 24/7, any damn doubt with regards to our Unacademy strategies, with regards to your preparation for your NEET PG, with regards to any queries for anesthesia subject. This is where you can find me on the Telegram group. The special classes was a recently concluded one that we had a marathon session. Yes, Anesthesia Achievers Club. I got a very good response for that. If you have not seen that, I would request you to go and have a look at those special classes as well. And we and Unacademy strive really hard to help you achieve your dreams, and let's crack the NEET PG examinations. All those who are new to the YouTube channel, don't forget to subscribe and hit the bell icon as well to know what we are coming up with next. So guys, how do you go about with the Unacademy app? This is where you can actually, after downloading the app, you can actually go for the NEET PG category of your preparations, and you can attend the free special live classes. Yes, there are a lot of free special live classes which we have taken. You can go and visit them as well as there are a lot of special live classes which will be coming up next as well. So go and look into those special live classes which are free, as well as once you are done with that, you can subscribe for the plus platform. We have got 1, 3, 6, 12, 24 months of subscription for you guys depending upon your appetite, and you can use the referral code, that is Dr. Hitesh, that is my referral code. So coming to the first question, let us begin our today's session. A lady with a history of previous cesarean section told the anesthetist that in spite of general anesthesia, she was aware of the procedure throughout the case. Yes, lady has to undergo now an incisional hernia surgery under general anesthesia. What should be done to monitor the depth of anesthesia? Yes, option A is color Doppler, option B pulse plethysmography, option C bispectral index monitoring, and option D is transesophageal echocardiography. Yes, I'm waiting for your answers, guys. You can write down the answers in the comment section. So, which monitor should be used to monitor the depth of anesthesia monitoring? So, even if you look at the question and if you read just the last one line of the question, you should be able to give this answer. Yes, this is just a straightforward one line of question, just twisted in the format of clinical based scenarios, right? So, it is just asking simply what should be done to monitor the depth of anesthesia monitoring. How and why do we need to monitor the depth of anesthesia monitoring, and what are the standard monitors that we use in anesthesia? You should know that. and why depth of anesthesia monitoring is coming up as a new mandatory minimum monitoring requirements under anesthesia. Yes, this is the next monitor in line which can be included in the minimum mandatory requirement for monitoring standards under anesthesia. So what are the monitors that come under minimum mandatory requirements of anesthesia? Yes, first is ECG. Yes, that is electrocardiography. Second, NIBP. Third, pulse ox, that is saturation monitoring. Yes. Fourth, capnography. And fifth one is your temperature monitoring. Now, apart from these monitors which you should know in and out, you should know one very important monitor, that is depth of anesthesia monitoring. Yes. Blood pressure can be in the form of non-invasive, it can also be in the form of invasive. Depth of anesthesia monitoring that we have now is a non-invasive depth of anesthesia monitoring. Yes, let us have a look into that. So this is how the depth of anesthesia monitoring looks like. You can read it from the name here. What it says, BIS. Yes, and it says here something as Aspect Medicals. So this was nothing but it was designed in the year 1992 by this company proprietary algorithm, that is Aspect Medicals. So what you can see here, there are these lids which are there on the fronto-temporoparietal part of the brain. Yes, so what is it monitoring? It is monitoring the EEG waves. Yes guys, are you able to get it? Just give me a quick nod. So these are monitoring what? These are monitoring the EEG waves from the fronto-temporal and parietal cortex of the brain. Yes. Apart from that, by utilizing the same thing, that is EEG, what do you do with EEG? You put up 16 to 18 electrodes all throughout the brain surface, right? And then you get the electrical activity of the brain. Now, this electrical activity of the brain, but this is a non-invasive technique, right? The same electrical activity is now being converted into a working algorithmic number that we get here, and this is the EEG waveform that you are getting here, right? And this proprietary algorithm of converting the EEG activities into the working algorithmic number that you get is the bispectral index monitoring. Yes, what is the range? It is in the range from 0 to 100. 0 means what? There is no electrocortical activity that is going on onto the cortical aspect of the brain. That is brain dead or patient in coma. Yes, no electrocortical activity happening. Then what is the depth of anesthesia that we require, that we maintain with this monitoring? It is 40 to 60. Yes, that is the depth of anesthesia that we require. So whenever we want, we can titrate our drugs in order to increase the depth of anesthesia, or we can reduce the amount of drug, amount of dosage that is going on to the patient to keep it in the range of 40 to 60. That is the ideal depth of anesthesia range when it comes to BIS monitoring. Yes. What is the next thing? 100 means patient is completely awake. Yes. So this is what you should know when it comes to BIS monitoring. Yes. What is the another monitor which is used? That is entropy. That is entropy monitor is also used for monitoring the depth of anesthesia. Yes, similar principles. It monitors the EEG. Yes, also has got a range from 0 to 100. 0 means coma, 40 to 60 is the depth of anesthesia with the entropy as well, and 100 is wide awake. Yes, and what it is, this is also non-invasive. Yes guys, got it? Everyone, I'm not able to see your comments, people. Just give me a quick nod, a yes or whatever. Are you able to hear me? Are you able to, give the answers? So what is the correct answer for this? It is bispectral index monitoring is the one that is used to monitor the depth of anesthesia. Yes? Moving on to the next question, people. Identify the image that is shown in the figure. Yes, Dr. Raslav, now I am able to see the comments as well. So identify what is shown in this figure. Is it option A, Mapleson A, option B, closed circuit, option C, open drop anesthesia technique, or option D, that is HME filter, humidifier moisture exchange filter? That is what is meant by HME filter. See, these are some of the topics which are so important when it comes to anesthesia as a subject, because very frequently these have been asked, and as I tell you time and again, that the examiner is going to ask you the same topic but in different manner. Yes, same question being repeated is very rare in today's scenario, and with the help of this online examinations now, the image based questions, the clinical questions, case based scenarios are getting more and more importance. Yes, so what is your answers, guys? Yes, Dr. Aslaf. So first of all, with the help of options also you can gauge that this is something related to the circuits, right? So what are the types of circuits that we know of? Yes, circuits are again divided into three types. One is open, semi-closed and closed circuit. Yes, people? So amongst these things also you can say whether this is a part of open, semi-closed or semi-open also that we call it, or closed circuit, so that you will be able to come and get to an answer. Yes, anybody? Okay, so this is nothing but this looks like a mask, right? And it has got this coverings on top. Yes, this is a Schimmel bush mask. This is known as Schimmel bush mask. Where is the Schimmel bush mask used? It is used in cases of open drop method of technique of anesthesia for ether anesthesia. Yes, remember, ether is not used nowadays, but earlier how was it used? This Schimmelbusch mask used to be kept onto the covering of the patient's nose and face. Yes, patient used to breathe through it. On the bar side on the top that you can see, we used to place the gauze pieces, and on those gauze pieces we used to drop the ether drop by drop on that. So what was patient doing? Patient was breathing the atmospheric air, but along with the vapors of the ether. Yes, the same way as in movies you see the chloroform thing going up. Yes, what does the villain do in the movies? He takes a handkerchief, puts something on that, and puts on the patient's on the victim's mouth. So what happens? Victim used to collapse. Yes, the same thing is here. Yeah, we are putting a gauze piece, putting down the ether from the bottle, and drop by drop the patient is inspiring ether vapors along with the atmospheric vapor. Since the atmospheric vapors are being inhaled by the patient, it is known as open drop technique or open anesthesia technique. Yes, there is no sophisticated circuit being used, there is no carbon dioxide absorber, anything. So semi-closed and closed circuits were advantages which were brought in later on with the help of anesthesia machine and other sophisticated instruments. This was used in the primitive times, so that is open drop anesthesia technique, which is also known as ether, which was used by that. So correct answer for this is, it is a Schimmelbusch mask used for open drop anesthesia technique for ether. Yes, don't worry Dr. Rutu, this is where we get to learn more and more. Yes, it is a part and parcel, because you should know a lot of time the questions has been asked on the semi-closed circuit, that is Mapleson system of circuit, but just one or two images on the same topic you should be able to understand and get it, because you never know, this can be the next question which can be asked in the examinations, right? And this has been asked once in Jipmer as well. So therefore, once you know the questions which have been asked previously, there are high probability and chances, because you cannot miss and you cannot afford to even make those questions wrong, right? That is a part and parcel of our preparations. Don't worry, we'll go ahead with next. So following are the indicators of difficult intubation, except option A is Malampati score 3 and 4, mouth opening less than 3 finger breaths, sternomental distance of 12.5 centimeters, and neck circumference of more than 40 centimeters. So what of the following are the parameters for difficult intubation, except it is asking? Yes, so Dr. Rutu says it's C. Yes, Dr. Aslaf. Most of the times that the examiner is trying to ask us, and we tend to forget what the examiner is trying to ask us, and we look at the question from our perspective. Yes, all of the following are parameters of difficult intubation, it is trying to ask us, except. Yes, so what and how do we determine a difficult intubation parameters? One, what are the tests that we perform for airway examination, and amongst these tests, which is a normal test here. Yes, first, yes, Dr. Aslas says C, Dr. Amit says C, Dr. Aslas says D, and Dr. AMD says D. Okay, guys. So Malampati score of 3 and 4. What do you mean by Malampati scoring, guys? First option was Malampati score. Yes, Malampati score is from 1 to 4, right? 1, 2, 3 and 4. In Malampati score 1, what do you see? You ask the patient to open the mouth cavity. You look into the mouth cavity and what all are the structures visible. Accordingly, you tell whether it is Malampati 1 or whether it is Malampati 4. Yes. As and when the grade of the Malampati score increases, the difficulty of intubation as well as increases. Yes. So Malampati score 3 and 4, are they a parameter of difficult intubation? Yes, they are a parameter of difficult intubation. 1 and 2, will they tell that the parameter of Malampati score 1 and 2, is it a comparatively anticipated not difficult? Yes, it will not be a very difficult intubation, right? So yes, Dr. Rutu, it is a parameter for difficult intubation, correct. What is the second option here? Mouth opening of less than 3 finger breadths. Yes. Now mouth opening of less than 3 finger breadths, what happens here? Whenever you ask the patient to open up the mouth, yes, what do you look for? We ask the patient to take the 3 fingers and put it in the entire inside the distance, yes, like this. If the patient is able to put the 3 fingers, that is the mouth opening is more than 3 finger breadths. Why do we require this? In order, when we are ventilating and after ventilating, when you want to intubate the patient, you need to put in the laryngoscope inside the patient's mouth. Yes. So for that ease of laryngoscopy, which is a part of intubation, you need to have an adequate mouth opening. If the mouth opening is not adequate, you will not be able to perform laryngoscopy. Yes. So therefore, a mouth opening of less than 3 finger breadths, what will be difficult? A laryngoscopy will be difficult. So in turn, what will be difficult? Our intubation will be difficult. Yes. Because after performing laryngoscopy, you need to have a space to guide the tube as well. Yes, the same happens with the Malampati grading as well. As and when the tongue enlarges in size, the mouth cavity, oral cavity shrinks. Yes, although the oral cavity is same, but the amount of tongue that is acquiring the oral cavity is more. So what is happening here? When you are performing the laryngoscopy and when you want to push the tongue aside, it becomes difficult. So anything with regards to laryngoscopy which makes laryngoscopy difficult will make intubation also difficult. Yes guys, remember this. Third option is what? It is about sternomental distance. So sternomental distance means what? The top notch of the sternum and the mentum part of the mandible. So sternomental distance. We ask the patient to extend the neck and we measure this sternomental distance. If this distance is less, that means patient is not able to extend the neck properly, or by default the distance is less than 12.5 centimeters. Yes. If it is less than 12.5 centimeters, it is a difficult intubation parameter. Yes. So when you are performing the laryngoscopy, the alignment of the axis of pharyngeal axis, oral axis and laryngeal axis will not come in proper alignment and laryngoscopy would be difficult again, and the guidance of the tube would be even more difficult. Therefore, the sternomental distance should be more than 12.5 centimeters, which is a normal thing. So what is the option here? Sternomental distance of more than 12.5 centimeters, it is a normal thing. So it will determine that it is not a parameter for difficult intubation. So option G is correct. Yes. Now neck circumference of more than 40 centimeters, guys. What will it determine? Anybody? Neck circumference. Yes. The neck fatty pad, if it is more than 40 centimeters, what will it happen? There will be a lot of fatty tissues in the neck. There will be difficulty in ventilation, and once you are performing intubation also there will be difficulty in visualizing the glottic opening as well. Yes, as in bariatric patients, as you see. Yes, so neck circumference of more than 40 centimeters, yes, it is a parameter for difficult intubation. So correct answer here is option C. Which are the two other parameters of difficult airway that we could do for airway examination? One was sternomental distance, the other is thyromental distance. What should be the thyromental distance, guys? What should be the thyromental distance here? Yes, Dr. Aslaf, it is seen in obesity, the neck circumference of more than 40 centimeters. And that itself is an individual parameter for difficult intubation and difficult ventilation as well. So here, thyromental distance, what should be the normal thyromental distance? Same as sternomental, if it is more than 12.5, it is almost half of that. It should, yes, exactly correct, Dr. Aslaf, it is more than 6.5 centimeters. And last one is your cervical spine movement. Cervical spine movement. Yes, if the movement is normal, that means patient is able to extend and flex the neck. That means the cervical spine movement is normal. If the patient is not able to do this thing while performing laryngoscopy, there will be a problem in the alignment of the axis, pharyngeal, laryngeal, and oral axis. If that is not aligned, you will not be able to visualize the glottic opening. Yes, got it, guys? So moving on to the next question. The most common artery for invasive blood pressure monitoring is option A ulnar, option B femoral, option C radial, or option D dorsal pedis artery. Yes, which of the following artery is the one that we use most commonly for invasive blood pressure monitoring? Remember, we spoke about 5 minimum mandatory monitors. Yes, of that second one that we spoke about was non-invasive blood pressure. Yes, when you take the blood pressure with an invasive route, that is known as invasive blood pressure monitoring. Yes, I'm waiting for your answers, people. Every question you should not take more than 60 seconds to answer max. Yes, because such questions, yes, Dr. AMD says there is option C, that is radial artery. What about other people? Dr. Rutu, Dr. Aslaf? Because clinical based scenarios questions is going to take at least 90 seconds of your time. Yes, so these straightforward one liners questions should not be taking more than 60 seconds. Okay, so ulnar artery, femoral artery, radial artery, dorsal pedis. What do we mean by invasive blood pressure monitoring? Let us have a look at this. So this is how a routine monitoring standard when we monitor inside the anesthesia room for a surgery looks like. Yes. So what it is showing? Yes, Dr. Aslaf is also saying that it is option C, radial artery. So green one that you can see here showing 63 as heart rate, it is ECG monitoring. Yes. So the blue parameters that you can see here, this waveform that is known as plethysmography, it is written here, it is showing SpO2, it is 100. Yes. The red one that you can see, the plethysmographic image, again beat to beat variation, you can see here something 134 by 78. Yes, that is nothing but it is showing the blood pressure of the patient. Yes, beat to beat blood pressure of the patient. So what do you mean by that? It is nothing but it is an invasive blood pressure monitoring, IABP. Yes. So which is the most common artery that you can see in this figure here? The radial artery has been cannulated with the help of a cannula. Yes, the same way you cannulate your veins, we have got a proper type of cannulation for the arteries as well. Yes, because it is a tubular structure, pipeline, same as your veins. So once you cannulate your veins, if you put a cannula inside the artery and connect it to a pressure transducer that you can see here, this has been connected to a pressure transducer. So what does it do? It converts the mechanical force that is being by the pulsatile force of the artery into a electrical force, which is showing in this monitor here. Yes, so this is the pressure transducer. Yes, so if you connect it to a pressure transducer and a pressure bag, it will show you what? It will show you the IABP, that is beat to beat monitoring. With every beat, with every pulse, whatever is the change in blood pressure, whatever is the change in the artery, whatever is the change in the blood flow will be reflected on the monitor. Yes, so that is one of the most advantageous feature of going for invasive blood pressure monitoring. Yes, why invasive is preferred over non-invasive when it comes to critical surgeries when the patient is having a lot of comorbidities. Yes, and which is the first of all, you should see what is the radial, where it is present. It is present here, right? So what is it? It is the ease of access that we get with this. Yes, femoral axillary, dorsalis pedis are the other arterial sites which we can put in the cannula for the invasive arterial blood pressure monitoring. But why radial is preferred? It is one of the very most important things is when the patient is lying on the table, which is the most easier thing to access? Radial. What do you palpate? Is the radial pulse every time. Why? Because of its ease of access. That is one of the most important parameters for this. Yes. Second, the blood to the arm, to the hand is supplied by what? It is supplied by the radial and ulnar. Yes. So the collaterals to the arm is very well developed. Yes. But to even rule out that, we have got a very important test to rule out the collaterals, whether the blood supply to the hand is properly developed or not. What is that test called? Yes, we perform a test which is by the name of AIIMS test. Yes, this is done to rule out whether the blood supply of the hand is proper, the collaterals are working properly or no. Yes, so in that we obliterate the radial and the ulnar artery. We ask the patient to blanch the hand, put in the fist, and then we ask the patient to open. Yes, after that we release the pressure from the ulnar artery. If the blanching of the hand is gone in less than 7 seconds, that means the collateral supply is good. If it does not go in more than 10 seconds, that means there is some problem with the collateral supply. So in that case, if you cannulate the radial artery, what will happen? After cannulating, there are chances that there might be thrombi or emboli formation or the artery going into spasm. If that thing happens, the collateral supply of the hand is already not good. Plus you have stopped the supply from the radial artery. So what will happen? There will be necrosis, changes of the hand, ischemia will set in. Yes, if it is going on for the prolonged period of time, what will happen? Slowly and slowly the patient's hand will turn into gangrenous. Yes, that is one thing that you should remember before cannulating the radial artery, right? So the most common artery for invasive blood pressure monitoring here is the radial artery. Yes, that is the best answer. Second most common is the femoral artery. Yes, there is institute to institute preference as well for this thing. Some people prefer to cannulate femoral artery over radial, but the best answer for this question that you can get is radial artery. Yes, what are the other monitors that you can see on the screen, guys? This 29, what is it showing? What do you mean by that? You can see here that these are graphs which are going up and down regularly. Yes, it is nothing but it is the EtCO2 graph. Yes, this here is showing a temperature. Yes, this is showing the MAC value, and here that you can see it is the train of 4 ratio, that is for neuromuscular monitoring. Then there is respiratory rate, and this is the mean arterial pressure that is showing on the figure. Yes, so if you see, this is a routine monitor that we are performing inside the OT. This is the same monitor that I use for my cases inside my OT for the cases. You can see all the minimum mandatory monitors here: ECG, pulse ox, blood pressure, temperature monitoring, and EtCO2. These are present for sure. But apart from that, we are using neuromuscular monitoring. MAC monitoring is available, and this 46, what does it signify, guys? You can see these are some waveforms which is coming here. Yes, it is nothing but it is a monitor that we have seen in the first question. Yes, bispectral index monitor to monitor the depth of anesthesia. Yes, so that is how a case, when we are taking up inside the OT, any major case, or if the patient is having any comorbidities, these are the minimum monitors that we do inside the OT, and these are the minimum monitors that you should know while performing and while giving anesthesia, as well as while solving the questions. Yes, these will form some of the most important questions when it comes to anesthesia as a subject. Any doubts till now, guys? So shall we take one more question? Identify this image that is shown in your figure. Yes, is it a nasopharyngeal airway, oropharyngeal airway, endotracheal tube without cuff, or tracheostomy tube? Yes, just a simple one-liner, again image-based question. These have been asked in the previous examination in the AIIMS last year. Yes, so this is what is it: a nasopharyngeal airway, oropharyngeal airway, ET tube without cuff, or tracheostomy tube? Dr. AMD says that it is D, that is tracheostomy tube. Is it? Dr. Asla says that it is B, oropharyngeal airway. Yes, Dr. Rutu, Dr. Ahmed, Dr. Joshi. It is nothing but, look at this figure, what it is having. It is nothing but it is a oropharyngeal airway that you can see. It is being inserted via the mouth and it goes and sits into the oral cavity at the posterior pharyngeal wall. Yes. So what happens when the patient is anesthetized, when the patient collapses, when the patient is not able to maintain the airway? Yes. What do you mean by that? The base of the tongue comes and falls on the posterior pharyngeal wall. So what is happening? The opening is blocked. So patient is not able to breathe. The respiration stops. Ventilation stops at that time. Yes. There is obstruction to ventilation. Yes. It is not that the patient is not breathing. There is obstruction to ventilation. So in order to relieve this mechanical obstruction, in order to relieve this anatomical obstruction, we put in the airways. Yes. It can either be oral or it can either be nasal airway. Yes. So this is a part of nasopharyngeal airway which we have inserted via the mouth. From this that you can see there is a tube inside which is hollow tube. From there you can easily ventilate. The gaseous exchange, air exchange can take place from there. Yes. So this is nothing but this is an image of oropharyngeal airway, right? Why it is used? What is the difference between nasal and oropharyngeal airway? What are the different types? What are the different sizes? That we will see in my next lecture of Anesthesia Simplified. Till then, where you can find me, guys? You can find me on the Telegram group that is by the same name, Anesthesia Simplified by Dr. Hitesh. Yes, and all those who are new to the YouTube, don't forget to click on the bell icon and subscribe to our channel. Yes, if there is any doubt, I'm more than happy to help you out now. Yes, people, any doubt? So shall we conclude the session then? So after this, you can go and you can download the Unacademy app. You can go and target for the NEET PG for your preparations and also look for the live classes that we have taken a lot. Yes. So in this live classes, you will get a glimpse of how do we interact daily with live interaction with students. There are plenty of interactions going on. And after that, you can subscribe for the channel for the Unacademy platform with these subscriptions which are available. And this is the code that you can use, that is Dr. Hitesh, right? Welcome Dr. MD, welcome Dr. Aslav. Yes, Dr. Aslav, that is also known as Kittle's airway. Very good. So until we meet again, guys, this is me, Dr. Hitesh, signing off. Take care, study hard, stay disciplined, and I'll meet you again in my next lecture. Till then, bye bye, guys. Take care.